Hey everyone, trying something new this time on my very last chapter of this information. This is chapter 23, and this is going to be chronic health conditions and special populations. So, this is the final concluding chapter for the NASM CPT manual and all of the chapters that are associated with that. So, it's kind of like a sum. It's not a sum up. This is actually a very important topic because you are, depending upon where you work and what you do, that could really lead to some of these specific, individuals you might be working with. So this isn't one of those chapters to take lightly. It's obviously still something that you have to get tested upon. So that's obviously a thing as well. So there's that as well. I'm saying as well a lot, kind of awkward. But anyway, let's move on. All right. So let's talk about chapter 23. As you saw before, the learning objectives are down there. All right. And really, really talking about what is special populations for our people. And so let's kind of dive right in. So age considerations, we have to take into account the massive physiological differences that happen between children and adults. One of the things that we have to be clear on is that, we can help children and we can work with children and all of that stuff that's associated with it. But you need to understand that there are very big individual differences between children and adults in things like peak oxygen uptake. I mean, that's super simple to understand that, there is a difference in our people, but it's one of those things where if we want to train children like adults, these are some of the things that we cannot do, because children cannot sustain high intensity exercise for prolonged periods of time. Their stamina and their ability of their muscles to continue to move are very different than our adult counterparts. Sub-maximal oxygen demands, or what we call economy of movement, that's really critical as well. Children have immature thermoregulatory systems, so they get overheated or they have a problem heating up in depending upon the cold environment versus the hot environment, whichever you might be talking about. It's immature, so it can regulate, but it doesn't regulate the same way that an adult would in that case. So and here's what it is. These four items: peak oxygen uptake, submax oxygen demand, sustaining high intensity exercise, and then immature thermoregulatory systems. You can see here that we end up having the comparisons of each. Not saying that they can't do those things, but there is a difference between them. Also, there's the glycolytic enzymes are lower than adults, meaning that enzymes are catalysts for a certain thing. So that's usually one of the main functioning reasons why, or physiological reasons why adults can proceed and keep going. Those enzymes control their catalysts for movement. So if they're running on the lower end for youth and adults have normally higher amounts, then there's going to be a difference in rep ranges. There's going to be a difference in endurance ranges. So that becomes very, very challenging. Or if it's under high intensity work, the ability to prolong that high intensity work is going to be more diminished. And then sweating rates, we talked about that a little bit, about how the immature factors of our our children, they just cannot tolerate the load that can happen. So can we get children to become more thermoregulated, more acclimatized to the weather? Sure, but again, it's still going to be up to their system on how they can provide that change and that help. So there's your, so again, going back to these tables, this is the full table right here. So for resistance purposes, for health and fitness, for athletic training, take a look at each one of these to see where the differences lie. So how are, again, what are some of the, details related to the youth? Here we are, what modes we, pretty much the same as what adults can, frequency, very similar. Intensity, again, you're going to be able to do moderate to vigorous, versus, very low for, because they can handle it. So what are you saying? 60 minutes per day. There's always some good fitness assessments that you can do that are related to adults. Flexibility, they can still do those things. Just understand that Children are going to be a little bit more, they're going to have a little bit more what we call joint laxity. They can just naturally have a little bit more mobility and flexibility than adults, because adults have those patterns instilled that make them less flexible. So this is one of those processes where you can, see the difference, but, doesn't mean that they shouldn't be stretching. It doesn't mean they shouldn't be taking care of, self-myofascial release techniques. But that's part of that process, is that we have to know that they can just function and move slightly different. Resistance training purposes, 1 to 2 sets, 8 to 12 reps at 40 to 70% intensity, 2 to 3 days per week. That's very generic. Again, it's going to be very individualized, but again, for test taking purposes, this is the pieces of information that you want to know. Progression is, so this is the key that we need to understand for children, though. Key for children is their resistance training. They're gonna adapt very quickly, but you need to understand that they're adapting very quickly, not because their muscles are getting larger, even though there is going to be some potential change in that. It's because their nervous system is creating new patterns, and so because their patterns are getting more ingrained and they're becoming more succinct and more synchronized, more connective, then what you're going to get is better movement patterns, which means better ability to move load. So that becomes critical in understanding that. But make sure you understand nervous system patterns before strength patterns. That's how the changes occur in that nature. Okay? So, and the last thing, like the very last line of this, is make exercise fun. The key to that is, and let's be real. I'm sure that you or I or your brother, sister, family member, friend, we've all had boring workouts at some point in time. It doesn't mean that every workout is like enjoyable, but for children, we got to make it fun so that they understand that, number one, it's an educational process, because children really need to enjoy it to help them become lifelong exercisers, and not even with sport, just in general. So we have to make sure that we're paying attention to that. Okay? So older adults, on the other end of the spectrum, there's going to be very big differences in terms of like what happens. So you're talking about gaining function with children, and now you're talking about degeneration or loss of function with older adults. And that's where the difference lies. I mean, you almost start on this like a pyramid pattern, right? You start low on the bottom of that pyramid, you build up into that upper peak as an adult, and then unfortunately you get that peak point, which actually works out well for the term. You hit that peak and then you kind of come down. So older adults, you're getting into that coming down part of everything, and that really becomes challenging, because now you're working with individuals who are losing function, and you want to try to help them keep their function. So you're kind of fighting a losing battle, but you can still help them as greatly as possible. So what are we also working against? Osteoporosis potential, arthritis potential, low back pain potential, obesity potential. We're also fighting against that whole premise of, and it's a cliche term, but it actually holds very big value, is if you don't use it, you lose it mentality. So, that goes with what the next little bullet is: reductions in muscle strength and endurance, range of motion or mobility, cardio fitness, and proprioception. If you do not use those, you will lose those. And not like completely, but you will lose those abilities to be able to sustain function and to sustain quality of movement. So what are we talking about in terms of changes? A maximum attainability, or a maximum attainable heart rate, cardiac output, muscle mass, balance, coordination, connective tissue elasticity, BMD or bone mineral density, and then anabolic hormones, hence loss of muscle mass. So these things are challenging to overcome, and it becomes a tough job for a trainer or a coach to be able to do something like this. So same as before, take a look at all of these. I'm not going to spend too much time, because these are all very simplistic, and in terms of like looking at it and reading it, there's nothing in here that's going to stand out as, oh wow, like that's a lot. So again, if you're looking at test taking purposes, I would definitely know your options. I would definitely know your times, your intensities, and know them inside and out, because these are things that you're going to end up getting tested upon. Okay. The one thing I will say to be careful of is that bottom one, pulse irregularity. And so if that's the case, if you have, any sort of heart conditions, or blood pressure conditions, or actually even any joint pain or dysfunction that needs to be addressed, make sure that you're getting your, and this kind of, I think, came in previous chapters, but get your, earlier on in your assessment stuff, get doctor approval. Don't go in blind and then have something happen to these individuals because they had a specific doctor's order that maybe they didn't tell you, or didn't mention, or forgot, whatever it might be. So just know your stuff. All right, there's your basic exercise guidelines. Very much the same as like what I was explaining, not the same numbers, but what I was explaining before in terms of frequency, intensity, time, type, all that fit principle stuff. Things for special considerations: slow progression, well monitored, focus on posture, right? We want them to be in optimal form with optimal technique. We want to get them to be able to be more independent. We want to make sure that we are very careful with how much they hold their breath in terms of the length of it. We want to have normal breathing. The Valsalva maneuver, for those who have like high blood pressure, it can be critical, especially as they get older. But understand that, this is some of the things that, we have to pay attention to anyway. But there are some things where you might have to hold your breath for proper posture. So it just can't be for long duration, prolonged periods. And then, obviously for mobility and flexibility purposes, we want to make sure that these individuals are using the right protocols like self-myofascial release and static stretching. Dynamic is going to be not as dynamic, obviously, as children and adults. And we're going to, it's going to be way more controlled so that they can still move in those patterns, but just not as regimented or bouncy like a child or an adult would. Interestingly enough, obesity has not changed in terms of like what they're about with BMI. There has not been any updates to this, and honestly, I don't know when that's going to come. I wish I had an answer. I hope it's changing now while I speak, because there needs to be a new way of classification. Because I'll give you a perfect example. I'm 5'11", and I weigh 220. I work out all the time. I'm in good health. Unfortunately, I think I was like roughly 30. I think I'm like 31.43 on the obesity scale. So I'm obese 1, and if I were to go to the doctor or whatever, they're gonna, it's labeled that way, even though my doctor, who used to actually be a client of mine, interestingly enough, he knows that I am in good health and I work out all the time. So, you're talking about the specific build of a person, but no, like it says, obesity is the fastest growing health problem in America and in most all other industrialized countries. Obesity, if I'm not mistaken, at this point in time has become the highest in terms of lifestyle or chronic conditions based on lifestyle of killing people and making people sick. So we need to be, aware of this, and we need to be, even though BMI is not exactly the greatest indicator of health, it does let us know the comparison of their height versus their weight. And, your job is to just, decipher and differentiate whether this person is in that good health yet in this classification, or honestly, if they're in poor health and deserve to be in this classification. I hate to say deserve because it sounds really bad, but you understand what I'm saying. They are in that. They deserve to be in that because of what their current status is, not that they can't change that. There we go. So, really, what are the causes of obesity? Sedentary lifestyle, age-related fat gain. People want to sit there and throw nutrition under the bus for that. Or quality of nutrition in terms of like what we eat. Sure, okay. But, again, we can control what we eat, and we can choose the quality of food we have. You can still make a difference on processed foods. Just you have to be very careful on what you're eating. So you can't fully blame it on the fat aspect, and that's critical for that. So we got to make sure that we're definitely paying attention to those aspects as much as possible. Um, so with exercise training, we have to be critical on that as well. What are we saying in terms of like the basis for everything? We are talking about making sure that we're fitting this regular regimented programming in. It says 2 to 300 kcals per exercise session. A minimum goal of 1,200 calories burned. That's very rudimentary, I guess would be the word I'm looking for here. And I know it sounds really bad to say that, but we can't put everybody in a box, right? If you have a 145-pound female who's maybe, just say she's 5 foot even, 145 to 150 pounds, if we can get her to burn 2 to 300 calories in a session, it's going to be a lot for her, depending upon how many sessions she has a week. But, the target is, honestly, with training, is to be able to get the best out of that person in that session. And if it equates to those kcals burned, then so be it. But again, especially if you're working with newbies that are coming back to exercise, who maybe have lived a sedentary life for the last 30 years, then you're going to be hard pressed to get them to burn 2 to 300 calories per exercise session because they just don't move a lot. But as they move and get better at moving and feel more confident in themselves, that can start to change. So, but I do agree with a combination of an integrated approach. Things like circuit training, cardio, resistance training, all those things can come into play. And then this is where I was going at, is that the modifications need to occur based on the ability levels of the people. There are, with obese individuals, there is a psychological aspect. I used to tell my students when I used to teach them in class, and even now I still kind of have the ability to kind of tell them. But the key critical element here is that when you're a trainer, you're not just a trainer, you're going to turn into a psychologist. And obviously there's a little bit of, sarcasm in that, but at the same time, there really isn't, because you need to understand that you're going to have to find a way to work with behavioral change and getting people to start feeling better about themselves and having a higher level of self-esteem, and understanding that, that working out or training can change your perception on how, your emotional status, and it can actually perceive a different social look for you. And so people start becoming changed in their confidence levels. They start feeling better about themselves. They start feeling better about the process and what we call self-efficacy, or the belief in their own abilities. So we have to understand that, a lot of these obese individuals, and I hate saying it because it sounds so bad, but they're down and out. They feel down and out, and some of them may not, but for the most part, many of them do. And it's tough, because now you're trying to take yourself, who doesn't feel confident about anything, and put yourself out there. And it's tough. I mean, that's no different than losing a relationship or losing a loved one. Any loss that we have becomes challenging, and it can become very, very tough on people. So when loss of this independence of feeling good about themselves or looking good in the mirror, that's gone when you're obese. So we have to figure out how to change that, and that's one of the things we're going to do. So like other things, there's the physiological considerations. There may be other issues going on. So that's why the initial screening is going to be very important. There might be things like hypertension, CVD, or CVD meaning cardiovascular disease, or diabetes, or something else going on. Dyslipidemia, where they might have problems with their fat numbers. They're going to definitely have a significantly reduced maximum VO2 max, or maximal oxygen uptake, and ventilatory threshold. So they're not gonna be as in shape as we think that we want them to be, or think that they are. Coexisting diets may hamper their exercise. So I'll give you a quick little tidbit. I had a client, before I went into, when I was regularly training, before I went into higher education. Um, he used to come in and he started looking really good, started paying attention to himself a little bit more, but then he got caught out by some of his peers, and it also made sense because he kind of went stagnant on his weight loss progress. Come to find out, it's called the halo effect, but what he was doing was kind of going back to some of his old ways. And the halo effect means that you're basically offsetting something that you think is good and stating that you can do something else because that good overweighs the bad that you were doing. And so what he was doing was he was actually leaving and going having breakfast every morning at Sonic. And because he was done with his training, he was always hungry, and he just wasn't losing any weight. And he got caught by his peers, and because he used to go to a 3-person small group training and enjoyed it, but then all of a sudden he disappeared after we talked about proper diet and nutrition. And it wasn't like a pointing fingers type of thing. It was more like, hey man, this is what you got to do. And so he went back to his old ways, coexisting diets. So you gotta constantly keep up with people and telling them that, like, hey, listen, this is the new change you got going on, but you need to you really need to just make that little bit more of an effort to help. And then measuring a body composition is going to be, it can actually be difficult, but it's going to be something that you need to make sure that you're aware that, I'm trying to think of the right wording here, but you're basically making sure that even though you might measure it, it might actually be like a false positive, I guess would be the best way to put it. And even though you measured it and it's like, oh, this person's only a 49 on the BMI, but you look and they're like 150 pounds overweight, it might not equate. I'm just throwing out rando numbers here, but understand that, the body comp testing for an obese person is probably not the most accurate thing to do at that moment. And you got to find the right mechanism to do it. And if that means that you have to use a different device, or you have, if the only thing you have in your gym is skin fold calipers, ditch those and just do some quick measurements. Just do some hip to waist ratios, or settle in. I hate using it, but sometimes it's appropriate to settle in on the scale, and keep that the BMI more prevalent, because as an individual loses weight, those are going to change, whereas the body comp may not, in terms of the testing, unless you have unless you have a DEXA scanner in your facility, or an underwater weigher, or a bod pod that really can help with that. You don't want to end up with, like I said, those false positives. Again, there's your numbers. But again, obese individuals, they're the same thing as what I was talking about before. Children, they adapt very quickly. When you go from doing nothing to something, you have that newbie improvement, like the new person improvement. And that helps a lot, and it helps them get, they're going to feel sore and they're going to feel beat up a little bit. But the principle of that is you're basically, the improvement is there. So again, be aware of those things, but at the same time, be aware that they're going to improve pretty rapidly before your eyes. And then they're like, oh, and then you watch them and you're like, oh, that 10-pound dumbbell, you think they're struggling with it and they're really not. And it's like, okay, let's open our eyes to what they're doing, because we don't want to be the ones that distract them from improvement as well. We could be thinking one way and we're watching them like, no, they need to be doing something more, because they're showing they can do more, not because you just think that they need to. They're actually physically proving it. So we don't want to be the deterrent of that as well. Diabetes, again, type 1, type 2. There is 2 other types that we kind of talk about. One is actually not diabetes itself, but it's pre-diabetic, and then gestational diabetes, which is during pregnancy. But understanding the differences: type 1 is insulin dependent, type 2 is non-insulin dependent. Type 1 is juvenile, type 2 is adult onset, and each one of them has their own concerns. So we have to be aware that type 1 is typically diagnosed young. Type 2 is usually lifestyle issues, and it's called adult onset for that purpose because it happens with age. Type 1, your pancreas doesn't make the insulin. Type 2, you become insulin resistant, which means that insulin's still produced, but the sensory mechanism, not the sensory, the actual mechanism where insulin and its receptors are not being received in the areas that are required to use insulin, so therefore you become resistant, and those receptors just don't do their job. So even though you're producing insulin in most cases, not all type 2 cases, sometimes type 2s do need insulin, but for the most part, it's usually an insulin sensitivity, a lack of insulin sensitivity, and a high level of insulin resistance. So we got to be aware that, of that purpose. So we got to pay attention more, for exercise purposes and dietary purposes. Again, taking a look here, again, diabetes is kind of like, the previous we talked about here with overweight and obese. You're going to end up with comorbidities, which can become very scary. Diabetes is in terms of metabolic syndrome, diabetes is prevalent in there. So same with obesity. Obesity is prevalent in the metabolic syndrome, like trio to quad approach. Exercise exerts an effect similar to that of insulin, meaning that you're gonna use carbohydrates effectively. So it's almost like exercise is gonna use it's gonna be almost like it's an insulin where it's going to use. So that's why it's important where exercise can actually help establish insulin sensitivity and kind of break down and try to help establish a better pattern versus, for the insulin resistance part of everything. Hypoglycemia can happen because you got to remember insulin wasn't doing its job. So now exercise is, individuals can go hypoglycemic, so you got to be paying attention to those blood glucose levels, but not eating improperly because blood glucose is messed up. Beta blocker medications can have issues. Hypoglycemia with excessive heat can be a problem. You got to be aware of increased risk of retinopathy, or what we call damage to the retina based on high levels of pressure. And then peripheral neuropathy, meaning your extremity nerves, making it very scary for individuals who have like blisters, or that if they cut themselves open could potentially have if they cut themselves open, they're more prone to infections. So all of these things need to be paid attention to, and that's why like it says here, use weight bearing exercise cautiously and wear appropriate footwear. Like all those things matter. There's your guidelines. Again, take a look at those. Look at, again, diabetics can do a lot of the very same things that a normal person can do. It's just it's going to be a lot more supervised, and there's going to be a lot more structure early on so that they don't overdo it, and then they can proceed into building into it. Hypertension, high blood pressure. 120/80 is that norm, but understand that, 115/75 is clinical norm. So, but 120/80 is that pattern. We got to be careful of individuals with hypertension because excessive pressure can cause changes and get people to pass out. So what are common causes? Smoking, sedentary lifestyle, alcohol abuse, excessive weight. There's that, so there you go again, how obesity can have can cause secondary concerns. So what are the health risks though? Strokes, CVD, heart failure, kidney failure, due to extensive pressure in those systems. And then, obviously the strategies, exercise, diet, and weight loss. And then on top of that, medication. And that's not anything new. That's something that's just been around. There's your considerations. Blood pressure response to exercise may be variable and exaggerated, depending upon the intensity level. So again, building people in. Although people take medication, people can arrive with what they call pre-exercise hypertension. So you got to be careful of that. So avoiding things where holding of the breath can be a concern, where heavy loading for resistance training might cause concern. There's the comorbidity part. Obviously, if you have hypertension, you may be put on a beta blocker, and by being put on beta blockers, that can really mess with your heart rate during training. Um, and then obviously it can also make an issue afterwards because your body is trying to very quickly reestablish blood pressure post training. So if you're on a beta blocker, it's trying to keep you low already, and then you're going to go post training where it might drop you a little bit lower. That can cause major concerns. So making sure we're paying attention to those aspects. There's your modes, your frequencies, your intensity, your fit principle, basically, and pretty standard. Nothing that screams from the rooftop that something negative can happen. There's your resistance training and other considerations. Avoid heavy lifting. Build into that. Doesn't mean that just because you have hypertension doesn't mean you can't eventually, but that's going to have to be cleared by the doctor for sure. Over gripping and clenching can cause excessive pressure. Tempo can be a problem because isometric, you're going to hold your breath a little bit longer, and then stand up slow. That's obviously a challenge because it can cause dizziness by coming up too quick. And then what we talked about before is that slow progression. Coronary heart disease, so CHD, again, a leading cause of death and actually a disability for men and women. So coronary heart disease is caused by atherosclerosis, or that blocking, which causes narrowing of the coronary arteries. And then, what it ends up with is what we call angina pectoris, which is chest pain, severe myocardial infarction or heart attack, or both. And then pretty common here, pretty common across the board, it seems like, with all these, is smoking, sedentary life, and poor diet. Pretty common. Depending upon how this heart disease resulted, you have to be aware of the impact of exercise and how dangerous it can be if you go beyond certain limits. It says clients with heart disease may not have angina or other warning signs, so that's a problem. See, that's where proper monitoring of that person is going to come into play. Just be careful of the intensity. So detecting, we talked about age predicted heart rate formulas and getting people to be in certain ranges. We got to be aware of that. And we might just be going based on RPE and how they feel. Hey, how you feeling right now? Can they talk back to you? All of those things. There's the comorbidity factor again. There's peak oxygen uptake. Because individuals with coronary heart disease have other things going on, and because they have a heart that's been compromised, they have basically a deconditioned heart, and so therefore they may not be able to build or up to a specific intensity because of that. So we have to pay attention and make sure that we're getting them into the right limits for that purpose. There's the guidelines there. Again, I would say that the intensity factor is definitely down. I mean, hypertension was up to 90% of your heart rate max. Here, you're talking about up to 75%. So that's a very big difference. And then, so modifying tempo, there's that Valsalva maneuver to pay attention to. The comorbidities can play a factor in multiple facets here. So avoid that over gripping. Again, progression of slowness, and again, these individuals may or may not have to, but more times than not, depending upon how severe they are, they may have to only be able to work in a standing position, or they might only be able to work in a seated position based on what their current condition is like. Osteoporosis, so low bone mineral density. Is lower than normal, and that is a really big problem. So osteopenia is where you have, where you have a lower than normal. Osteoporosis is bone density that's been completely compromised, whereas osteopenia is lower than normal bone mineral density, which eventually can lead to osteoporosis. So osteopenia is lower than, and then osteoporosis is a loss complete loss of. We have to understand that there's a lot that goes into it. Osteoblasts just do not build back up that bone, and you end up having a bone that kind of looks like a ripped apart sponge versus a sponge. If you look at how a sponge has a porousness to it in terms of like especially on the ends where the spongy bone is. But what happens is that spongy part, and then actually the long bone, which is hard, not spongy bone, they can start breaking down. They have they just completely get chunks taken out of it, and that can become a problem. There are, osteoporosis can be considered two types, type 1 and then type 2. Type 1 being primary, type 2 being secondary, meaning that secondary is usually caused by some other concern, medical condition. It can be caused by medications, whereas primary is because of aging, based on hormonal, imbalances. So that can become a major factor. So risk factors, though, for osteoporosis: low peak bone mass, lack of physical activity. Don't forget, at physical activity, especially weight-bearing physical activity, helps bone constantly turn over. That's what we want to pay. That we talked about that way earlier on in the earlier chapters. Lack of physical activity, smoking. There it is again. Excess alcohol consumption, and then low dietary calcium intake. So just because you say low dietary calcium intake does not mean you make people constantly drink milk. There are plenty of other food and drink sources that you can get your calcium from, not just milk. And I'm not saying that because like I'm afraid of milk or anything. It's just that's where people jump to, and it's like, oh, well, that means I got to drink more milk. It's like, no, you just need to have more calcium in your diet. And then as you get older, you may have to become supplemented with it. There's your considerations. Gait and balance can be negatively affected. Max oxygen uptake again. Vertebrae problems based on bone problems. And then, you can end up with age, disease, physical stature, and deconditioning that can lead to falls because of this lack of bone and basically the strength of this, or the stability and strength of the skeletal system. There's your guidelines. Again, lower intensity, lower than coronary heart disease. So paying attention to those types of things. All right. And we talked about the special considerations from the previous slide. Arthritis, inflammatory joint condition. You can have osteo or rheumatoid. So basically what ends up happening is osteoarthritis is cartilage, usually is, lack of cartilage or a deterioration or a degeneration of cartilage. And what ends up happening is you end up having the inflammation of that affected area, what you could end up with too is you could end up with new growth sites, which what ends up happening is that inflammation takes over and your joint becomes so painful that you have a hard time moving in general. And then rheumatoid arthritis is where the immune system attacks its own tissue, and in this case you have an inflammatory response of the joint because it's being attacked by you. So that can become a massive problem. And if you notice, they're very similar in their areas. Osteoarthritis is more pronounced in like the hands, knees, hips, and spine. Rheumatoid arthritis is hands, feet, wrists, and knees. Not so much the spine, but it doesn't mean it can't affect it. Considerations, there's that max oxygen uptake is going to, lower because they just can't move as well. Medications can be a problem. Tolerance can be a problem because of these flare-ups and, an inability to do the things that you're supposed to be doing. Arthritis, can cause early morning stiffness. So therefore you might end up having to change your workout times with them. And then there's the comorbidities, like with arthritis, you end up with possibly osteopenia or osteoporosis because of that, breakdown that's occurring from that inflammation. So again, lower intensity than most of these 40 to 65%, and it's going to be basically dependent upon how well they can do. But yeah, seeing everything else that goes in there, avoid heavy lifting at high reps. That can be and then what you're going to try to do is find the best pain-free ranges of motion for them. So even though you want them to go completely overhead, or you want them to go completely straight out with their shoulder or whatever, or you want them to do like wrist curls, and there's certain things that you're not going to be able to do because it's going to cause pain, and we do not want to do things that cause pain. So we have to be aware of that. Cancer, one of those things that it's tough. It's really, really tough. And, all of us have felt that in some way. If you have never, then you're probably one of the luckiest people on this earth, because it can be tough on everybody, including that person, obviously. Exercise has been showing to be a really good defender of those individuals going through treatment. So even though you're going through treatments of cancer, training, although these people are fatigued, the exercise itself can, basically help with feeling less fatigued, because you're gaining more muscle mass. You're improving your endurance, that your life can improve because you're feeling better. But it doesn't mean that although there can be adverse effects, we're hoping exercise can balance that and make an individual feel a little bit better. But understand too that medications can have really nasty side effects. Like it says here, peripheral nerve damage, cardiac and pulmonary problems, skeletal myopathy, or basically muscle myopathy can either be muscle weakness or muscle wasting, one or the other. Anemia, and then nausea. So all those things can cause an issue with quality of life, but we're hoping that if we can push exercise in there in some way without, strapping these people of whatever ounce of, ability they have, like if you don't feel well, it's like, oh, well, if they are like keeling over and hurting, it's like, well, we got to be aware of that. It's like, oh, let's go exercise. Well, no, let's read the room. So it just, we're trying to get them to be feeling better, and by working out a couple of days, 2 to 3, 4 or 5 days, if depending upon their level, if possible, then we want to try to get them in there. Fatigue, we talked about. It can cause problems with immune function, and one of the things that happens with our bodies at the time is that immune function can get broken down just from general exercise. So we got to be careful of already taxed immune system already. And then with people with cancer, we got to be aware that they are, lean. Their lean muscle mass can already be down. So we got to pay attention to that. Upwards of 70%, which not too bad. 3 to 5 days per week, build up as needed. But then again, what are we talking about? Avoid heavy lifting, but it's as tolerable. Allow rest intervals. They might need a little bit more than the average person. And then progressive, conditioning to get them higher involved. Or not involved, but get them higher involved, so that they can start building their stamina up and start to, break that pattern of feeling fatigued, and really push, help push the envelope to make them feel better. Pregnancy. I've known people that have gone almost their whole terms, working out. But there are certain specific requirements that doctors will give to their people, that after the first trimester, after the second trimester, as they get into the 7th, 8th, and 9th month of their pregnancy, there's certain specifications that they can and cannot do. And then obviously there's that factor of any type of fluid that's coming out of them that's not supposed to be is an immediate cause of concern. Bleeding is a concern. Any pain or extra contractions are a concern, and we have to make sure that we're aware of that in their presence with us, but also if they come to us and have talked about it, because that might minimize how much training they're going to be able to do, and they're going to need more doctor orders. So that's really, really important. But also, I would also check with, the individual to make sure that you're always getting the doctor orders, so that you know what to expect, and what the doctors are telling you that they can and cannot do. So there's that bleeding part that I was talking about. There is a decreased oxygen available during aerobic exercise. We got to be paying attention to that. It's going to be more challenging for them to breathe because their diaphragm is in a whacked out position as well. Posture needs to be accounted for, so intensity might have to be adjusted because their stomach is protruding, which changes their whole aspect of their lower back dynamics, and that can also affect nervous system output and blood flow as well. There's going to be a change in calorie output, so therefore you're going to have to pay attention to, are they eating enough? And you might want to talk to them about that. Although we can't get too much into the nutrition component, we can still ask questions. And then there's that aspect of high risk pregnancy for those older than 35, anybody who's had any history of miscarriages, diabetes, thyroid disorders, anemia, obesity, and any other sedentary lifestyles. We have to be aware of that because high-risk pregnancies can cause problems for those who are exercising. The key here is, my rule is, in the first trimester, if you have never worked out before and you're coming to see me now, I'm probably not going to work with you. And that was my rule of thumb. And I hate to say that, but anything after that first trimester, because you're trying to get somebody who's now growing something inside of them, and you're trying to get them to function correctly in terms of exercise, but they've never exercised before. So it's kind of like hurting itself. So I always say, if you're coming to me late, in your pregnancy and you've never worked out before because you're afraid of gaining weight, then I'm probably going to turn you down, and it sounds really bad, but it's going to be hard on your system. And the experience that you're going to have is going to be tough. The training programs that you're going to go through, although they're going to be adjusted for your ability, are going to be tough because you've never done it before, and there's undue strain that really doesn't need to happen. Sounds kind of harsh, but that's just the reality of it. There's your intensities. Like I said, every person's in their own individualized state. So, focusing on what you can and cannot do. But again, avoid exercises in the prone or on your stomach or supine on your back after 12 weeks. Very, very careful with that, especially if you're, for people who like to do I like planking. It's like, yeah, but after that first trimester, and especially if your belly starts to become more pronounced, although it doesn't happen in the first trimester, you'll show maybe a little, but, it's still, you don't want to put yourself into that position. Plyometric training is not advised in the second and third trimesters, again, based on doctor orders. So be careful of that. Can become very, very, you might be hurting that person by not allowing them to train a little bit more. Some people can just do a little bit more in that time frame. Chronic lung disease, like restrictive lung diseases, chronic like COPD, that can be, all of these things need to be aware, and that's really going to affect you. So, and fibrosis is a thing, COPD is a thing, bronchitis is a thing, asthma, emphysema, all these things fall under this facet of chronic lung diseases. And it's going to have a big bearing on what a person can and cannot do. Again, lung disease usually has a comorbid state. There is a huge problem with gas exchange, cardiopulmonary exchange, meaning blood and lung functioning, and getting carbon monoxide out of the system, and getting or carbon dioxide out of the system. I don't know why I said monoxide. Carbon dioxide out of the system, getting oxygen into the system. There's that really big pulse ox issue, and that's why when you put the little thing on their finger, the pulse oximeter, you want to make sure that you're seeing these numbers being above 90. But clinically, you really want it to be above 85, and that becomes a challenge. So, if you're starting to see these people fade like that, then it's going to be more of a concern, and you got to stop them. Like this is chronic deconditioning, so we got to be able to build these people in properly, because their workload is not going to be very aggressive. The one thing is, upper extremity exercises are going to be they're going to be more of a fatigue than if you were to do lower. So you got to be aware of what you're doing in terms of dyspnea and then fatigue. And then, muscle wasting can occur because of this factor, because lung disease, can cause muscle wasting just because of what they are or are not doing. And then certain individuals might come to you with supplemental oxygen, which changes the game. Certain people might have inhalers, which change the game. So there's a lot of factors that come into play with that. But if you notice, the intensity is very low. 40 to 60% of peak work capacity. Well, their peak work is not going to be very high. So, and if you notice, their assessments are and their flexibility are if tolerated. That shows you the severity of what's going on in this facet. So just paying attention at all times with these individuals. Now, intermittent claudication, or sometimes you might hear it called peripheral vascular disease. You might, basically what you might see is, limping. You might see like their leg dragging. They might complain about pain. And what it is, if they have any of this, it's basically where the artery is reduced. Basically there's a reduction of blood flow to the limb, and it's causing the change in that. All right, so it can become very challenging. And some people might have what's called peripheral arterial disease. Like it says, a group of diseases in which blood vessels become restricted or blocked, typically from atherosclerosis. And then, like I said, it's usually a factor of pain. And because of that lack of blood flow, you're really having a more challenging time getting these people to do things because they can't move. So there's the coronary artery disease, or diabetes might be a past thing as well. Not to mention, they might have intermittent claudication or PAD, so that's a problem. So you got to be careful of that in terms of establishing their upper workout limits. Smoking, if they haven't stopped, they need to stop now. But that might make them worse when they're with you, because they're not taking on that. It could be a decreased aerobic capacity, which we talked about, because of the lack of their movement. Resistance training is really, it can help improve, but they're lacking in what they can and cannot do. So you got to be aware that it needs to be a part of their process, because without it they can really struggle, and by not giving it to them, they're going to struggle with their health. So it's a catch-22. And then lastly, last slide of this whole thing, just kind of going over it, but you can see there the intensity can be up 50 to 85%. That's not a bad clip. So just be aware that these things are there for that purpose of understand that if it's a lower intensity, that person's probably in worse shape than if it's a higher intensity. So just got to be constantly aware of what the conditions are, and that's why those pre-screenings are really important, because it'll show you where these individuals are. And I hate to say like labeling people, but this is a good label to have, because it's going to show you like what they can and cannot do. Now, these are just basic guidelines. At any point, if you have somebody in these categories, you're going to have to do some research, and you're going to want to see what's some of the best functions that you can do with this. All right. So, like I said, this is chapter 23. This is the last one, right? I hope you all enjoyed these videos. It's one of those things that I enjoy doing for you all. So please feel free to leave some feedback. This is one of those chapters that just kind of, there's a lot of information in it that, in terms of like percentages and values and times and exercises. So just pay attention to it all. And it's along with every other chapter too. It's just, some of you may work with some people who are considered special populations, some may not. But understand that it's all across the board. So you just never know who you're going to have come walking through the doors. But thank you for everything. Thank you for listening. I hope you all have a really great rest of your day, night, weekend, whatever time you're listening to this on. And we'll come back again soon and do some more, because there probably is going to be some indication of probably at some point an update to the edition for a textbook. So you never know if you'll see some new videos out there. So again, thanks. Have a great day. Talk soon. Dr. Jeff. See ya.